Good morning, everyone. I think we're going to get started. I'm Maura Inkelis from the University of California, Los Angeles, and I wanted to thank and welcome everybody on behalf of the many organizations and individuals who have helped pull together the symposium this year. I just wanted to say how excited we all are to have this opportunity to share some of the bright spots in our work, to share ideas for doing a better job of supporting innovation and improvement in our local health systems and public health and community systems of care in Southern California, and to share how we're going about solving major innovation and improvement questions, and solving some of the major challenges in systems, sparking collaboration, and also coming up with strategies for how we could strengthen infrastructure within Southern California to achieve system solutions more efficiently and in better partnership with our local system partners. Brian Mittman will have an opportunity in about an hour to share a bit more about the structure of the day, but we wanted to kick off the meeting with some introductory comments and welcoming comments from two leaders of Clinical Translational Science Institutes in Southern California, Dr. Dubinett from UCLA and Dr. Buchanan from USC. And just want to welcome them, and we're so pleased to have them here. We're just so grateful for their leadership, their listening, their willingness to think about resource and strategy opportunities here in Southern California, and the partnership with, I think, local systems in the county and in health systems as well, and thinking through strategies of what we can do better together to build a more capable infrastructure so we're equipped to solve issues going forward. So I want to welcome them and make some introductory comments, and then we'll get started with our day. Thank you.
Well, welcome to the Southern California DII Symposium, and we are characterized by a group of people who have broken down the walls of our institutions and the usual academic silos that prevent us from working together. As I look through the program and some of the abstracts, I realize that that's a salient feature of our work together. It's not only UCLA and USC together, but working together with the county. So we had a chance at the CTSI meeting to present the work that we're doing in this three-way collaboration. And I have to tell you that it was received with great excitement and praise. So the work that you're doing from Southern California is gaining national recognition. And in addition, along with the themes of really breaking down the walls and working together, I discovered this morning that Southern California now stretches to Davis in San Francisco. So we congratulate all of us for being part of this symposium and looking outward. It turns out that in human evolution, when we needed to work together to gather food, our brains grew. So welcome to a symposium in which your brains will grow. And we're thrilled to be part of this, to work together with you in DII. Tom.
Thanks, Steve. And I guess the inclusion of Northern California and Southern kind of puts to bed the idea of cessation of Southern California from the Union. But I guess most of us want to secede from other parts of the country right now. Anyway, you guys have a very big day, and I'm not going to take up too much of your time. I do want to say thank you for having me here on our CTSA. It's been really exciting to work with Steve and the UCLA CTSA and the Department of Health Services to develop a pilot program to do implementation science with the Department of Health Services. It's a very different paradigm than I think we're used to in academia, because it's not just about getting grants and writing papers. It's actually working with Hal Yee and his teams. It's about doing things that will actually make a real difference in day-to-day operations of the county, which makes a big difference in the day-to-day health of the patients that they serve. And I know there are people here that work in other large health systems. I think it's for the USC side, it's been a movement toward understanding implementation science and recruiting new faculty to do implementation science. The lead of that is Michael Hackman and his Gear Center. I know Michael will have a prominent role today. So USC is really committed to moving in this direction. It's one of the the new areas. We're developing a new strategic plan under a new dean, and outcomes research and implementation science are a new area that's going to be highlighted for the university. So we look forward to expanding our faculty expertise, to expanding our interactions, and to working with you all to have a big impact on the health of people in Los Angeles. So have a good day.
Thank you so much. So next we wanted to welcome Hao Yi, the Chief Medical Officer from Los Angeles County Department of Health Services. And we're very pleased in the next segment to include both Dr. Yi and Dr. Crowe from the County Department of Public Health to really, I think, lay out a charge for us to think about what are the problems we're trying to solve, how we can do better as people within systems, as researchers, as scientists, to partner together to solve problems. How do we need to do things much differently in the past? And so I think to lay out that charge for us, and I think the comments that we'll hear in the next 40 minutes or so will help frame the rest of the day as we think about how we're doing our work and what we can all do better together, and what strategies we can come up with throughout the day and going forward to equip ourselves better to do the kind of problem solving and support that Dr. Yi and Dr. Crowe will lay out for us. So thank you so much for being here.
Thanks, Mara. I guess the first thing I wanted to say is it's hard for me, if I went back to about 6 years ago when I got here, to imagine that we would get to the point where we would have UCLA and USC in the same room sharing resources with the county, DHS, DPH, and people from the VA and from Kaiser talking about how we actually improve care, how we improve how we deliver care. I think that this in itself is a transformational thing because the kind of work we're talking about today is really team science. This is the team science, not necessarily those linear particle accelerators and all the genetic things. It's really this sort of work. And now that I've said sort of the nice, positive things, I'm going to chide people because I want to talk about, I guess, what I'll call the efficacy effectiveness gap. What do I mean by that? I don't have to tell this group what the difference is between efficacy and effectiveness. But I had an example of that when I was driving in this morning. So a few weeks ago, I had a nice chat with Mara, I think Brian, some other folks about what was going to happen today, what they wanted me to talk about to tee things up. And that was great, right? That was efficacy. I'm going to stand here, I'm going to talk about all this stuff. You folks are all going to be transformed in terms of which direction you're going to go. There was a problem. I had to get from my home in Palos Verdes to here. So I figured, okay, I'm going to leave at 6:45. Generally, an hour and a half should be plenty of time. And I got on the freeway, and I'm going on the freeway, and I hit traffic. And then, I had my navigator thing on my phone and saying, get off on Manchester. I'm like, no, I'm not going to get off on Manchester and go up Figueroa. So how do I get here? How do I get here on time? How do I get here on time to share with you? And I think that's the difference between what we at DHS really need. We don't need people to sort of tell us the great idea. What we need is people who will partner with us to actually get there, right? What are all the decisions that you have to make to get here and give the talk? It's not the theoretical stuff that I was talking about here. This is how we, this is what we need to present. This is the direction we need to go. I literally had to get here. And I couldn't have got here. Well, a lot of you are young, so, your post-phone GPS navigator. But any of us, who are older than about 40, 45, who lived in LA, would, as soon as they hit traffic, they'd be thinking, all right, do I get off on the 91? Do I take the 710? Do I take the 605? Do I take the 105? Do I take this surface street? Do I take Figueroa? That's the part that's necessary for effectiveness. Let me give you another piece of evidence, a story about how big the gap is between the folks who want to make these changes, who are really thinking deeply and profoundly about how do we improve healthcare services, delivery, implementation, dissemination, and those of us whose feet are on the ground actually trying to take care of patients or manage people taking care of patients. So to me, a real paradigm shift, something that we can all be very proud of, is that Tom and Steve and I, after a few years of discussion, my CTSI colleagues suggested that we go forward with a grant RFP process for implementation, real implementation. And, you know, I think it's actually unique. I think it's unique in a couple of ways. One, that it's truly an implementation RFP. And second, that it involved DHS, USC, and UCLA. So, given the relative lack of traction I've had these 5 years, was not necessarily that. I was hopeful, but not planning to get a huge number of applications. And so we got almost 40. I was so pleased. I mean, just to get 40 from UCLA, USC, and DHS folks was amazing. 40 people who really had the idea of making a difference in the healthcare we provide. So then I read the letters of intent. And immediately I realized there was a gap, because only 10 out of the nearly 40 letters of intent indicated any potential to make a difference in our system. And we had a meeting, again, transformative. When was the last time the grantees got to meet with the study section? So we really let them do that, right? We answered questions. And of the 10 that had a potential, only 5 of them decided to put forward the application, the full application. And we funded 2. And I think the 2 we'll fund will be paradigm shifts, because they're truly oriented to implementing something that will improve how we give care. But the yield on that, 2 out of 40, is not terrific, right? I'll take 2 out of 40 in my old study sections where people are doing discovery, trying to figure out what molecule controls this signaling pathway. But if we're actually talking about operational changes that are likely to result in improvement in healthcare delivery, and that's what the funders, UCLA and USC, were willing to do, and us, we're funding the operational piece, then it's sort of disappointing and depressing that from such enthusiastic, well-trained, high-minded, mission-driven, value-oriented folks, that we actually can't figure out how to make a real difference. So in my thinking about those 40 or so letters of intent, I guess I wanted to figure out how to provide guidance to myself in terms of those grants sort of didn't really make, I mean, a lot of them didn't seem like they would make a difference. But I didn't want to be completely subjective, ad hoc, read it, say no, read it, say yes. So I tried to come up with 4 principles that I shared with the CTSA colleagues as to what might make the kind of project that you folks might do that would actually help us advance how we provide healthcare delivery. Number 1, it actually has to be a solution to a problem in healthcare, as opposed to a plan for measuring or understanding a problem or developing a solution. There were a lot of projects that you could see that was the thing that person does. They either do that methodology or that's their, they probably had one of the great mentors we have in health services say, well, you did all of this already in college or residency, you might as well just build on that. Except if it doesn't solve a problem, then who cares? At least I don't care. So we need to make sure that we have solutions to real problems in healthcare. Second, if you're going to do this sort of health delivery, dissemination, implementation work, you actually have to align with the health systems, not the health system writ large, the health system that you want to help work with. You need to align with that health system's specific infrastructure, business approach, and operations. Here's an example. Recently, and I'll try to not talk about specialty. It's hard not to talk about the organization, though. Somebody proposed an intervention. And the reason they proposed the intervention was because it's worked tremendously well at Verdugo Hills Hospital. And they want to propose it at LACUSC. And they said, because it works at Verdugo Hills, it will work at LACUSC. It's a little bit naive to think that Verdugo Hills' business model has anything to do with the LA County USC business model. Fee for service, managed care, safety net, nonprofit. Academically, it sounds good. But in terms of actually making it happen, you kind of have to know what's going on in the health system you're talking about. Third, one wants a project that involves broad participation across sites and disciplines, as opposed to single specialty, single hospital, or single clinic. If you're working with a health system, whether it's DHS, whether it's Kaiser, whether it's the VA, whether it's UCLA or USC, they all are multi-hospital systems. And the cultures are all a little bit different. The people are a little different. The geography is a little different. This infrastructure is a little different. If one wants to do something, doesn't make sense to tailor it to a single site in a large integrated system of care. One has to think about, is this going to spread? And is it going to be sustainable? And it's hard to spread and sustain things if you do a tiny little efficacy pilot project in one site, in one specialty, in one discipline. So we got to really try to move towards involving broad participation. For many of you, you're interested in community projects, places that are at the interface of the health system and the community. You really have to engage the community then, right? You have to think about who are the stakeholders that you have to engage. And the fourth thing is to focus on effectiveness. That's an intervention predicted to work in real life as opposed to efficacy. Not, at DHS, we're not really that interested in interventions with randomized controlled trials to show whether something works. The reality is for us, there are enough molecules that have been discovered. There are enough medications and devices and processes that have been discovered. There's enough efficacy work out there, including really great stuff you have all done. It's sort of time for us to actually work on projects that are geared towards effectiveness. I guess that's probably all I wanted to say. I really think that we need to close this gap between efficacy and effectiveness. And hopefully I've just shared with you some of the principles to consider to help you bridge that gap.
Thanks so much, Hal. Just wanted to say also we'll see, we may have time for one or two questions at the end of this session, so we'll hope we have time, and if we don't, I think we'll have time to talk about these themes throughout the day. So I want to introduce Dr. Crowe from the LA County Department of Public Health for offering his perspective on the day.
Thank you, Maura. And it's always great to follow after Hal, because then I don't really have to talk about much of anything. But I think to reiterate, the concept of team science and that gap is sort of the same thing we've been experiencing with public health, from a public health perspective. I kind of look back to about 2 years ago. I actually was at this symposium kind of talking about sort of the same thing of what dissemination, implementation, improvement science can actually offer for public health. And one thing I will say at the time is we had a lot of ideas. And I'm going to try to refresh some of the ideas in my talk, in my message this morning. But the one thing I also want to share is what some of the progress we've already made since 2 years ago. It's always very refreshing to kind of think about where we were and where we are now 2 years from now, 2 years later. So, public health, our mission is actually broader than just health system delivery, but we obviously interface with them quite a bit. In LA County, obviously, our mission is really to build healthy communities so that, you have healthy people who actually live in healthy communities. We obviously try to protect health, prevent disease, and promote health. And we're trying to do all this, obviously, if you look at the budget, $850 million for such a large county of 10 million people isn't really quite enough. And as you can see, it here again is sort of the major public health responsibilities. And in the era of healthcare reform, we obviously have a lot of landmark issues that we could address and actually take advantage of. Of course, with last year's elections, some of this is a little bit of a question mark this year. But the way we've kind of thought of from a public health perspective is we kind of continue to march along and kind of adapt to changes that come about. Now, in terms of, as Howard mentioned, some of the problems we face, again, he's exactly right. We're not really looking at trying to document yet one more extra disparity or to sort of try to determine whether or not intervention actually is efficacious. This graph, I put this up because this is to show you how public health and probably even the health system have to start thinking about their problems. It's not just obesity and it's not just diabetes, for example. It's the fact that both of them are connected. It's the fact that all the intervention and strategies we have to do and we have to think about, it's very system related, it's very community related, and we basically have to address both of the problem at the same time. I know in the diabetes world, they call the epidemic not necessarily a diabetes epidemic or obesity epidemic, it's really a diabesity epidemic. Same idea, I'm going to skip forward here. We recently had a new director of public health, Dr. Barbara Fiera, and I know in talking to her when she first came, she was very interested in health inequities and health disparities, and I kind of said that, well, you're in the right place, because in LA, we've been documenting health disparities for a number of years. Our major problem is we have not had the sufficient strategies to actually significantly reduce them. So as you can see, even in chronic disease, you look at South LA and the West Los Angeles area, and you could tell that adult obesity rate in South LA is 3 times higher than that of West LA. And not surprisingly, in terms of diabetes mortality, 43 per 100,000 in South LA, but you're looking at 14 per 100,000 in West LA. And at least for public health, we're facing new issues and new emerging public health problems. E-cigarettes use is starting to emerge as one of our issues in tobacco control. Just when we thought we passed enough city ordinances across LA County, these things, we're going to have to sort of start again to try to make sure that those ordinances are actually updated in terms of e-cigarette. And then on the horizon, we also have the issue of the Prop 64 with the marijuana smoke. That being said, public health has been looking for sort of dissemination and implementation sort of strategies and ways to actually look at whether or not what we're doing is actually meaningful. And for the reason that a lot of the determinants of health isn't just in the clinical setting, it's that sort of the gap, I would say, extends to that area between community and clinical linkages. And this I like to show. This one actually is from the Institute of Medicine. I believe they're called National Academy now. But it's just to show you that social and economic factors and other social condition issue are actually plays quite a large part of what determines healthy communities and healthy populations. So let me jump ahead. So what are we interested in? 2 years ago, when I reflected on this at this symposium, we talked about interventions, especially those in the community. Oftentimes, the research that we've seen tends to be, does this particular intervention actually work for this particular population or for this particular community? And as Hal indicated, a lot of the efficacy studies are there. There's plenty of study that just looks at that one single intervention. What we're probably moving towards and we're more interested in is what are the combination strategies that actually together implemented in a more sort of strategic way actually benefits population health. And that kind of takes us to, maybe that's why all of us are here, is start thinking about how do we actually use combination of research methods to actually study these problems, right? Because what it implies is when you're looking at combination of strategies, it implies several things. One is it's beyond just a single intervention efficacy. It implies that we need to look at interactions between the intervention. It also implies basically all the different barriers and logistical issues that comes with implementation. And what that also implies that we probably need to think creatively about which methods we're trying to use and how we use them to actually answer questions. So that kind of brings up sort of the issue, as I've talked to Maura and others in CTSI before, at least in public health, sometimes we feel like we're always asking the wrong question, right? I think in the textbook they call it type 3 errors, which is it's not so much the research is the problem, is we probably started out with the wrong premise and probably asked the wrong question. So reflecting back from 2014 to now, so what have we actually started to build towards in order to sort of move this forward? One of the things that we've really been able to do, and this is, I should give this sort of shout out to like Steve Dubinett and CTSI. They actually put in they allow us to kind of build a population health program under the CTSI to kind of begin to deal with some of these issues. And through that unit, we've started to ask, at least in a public health standpoint, some of the more upstream issues that we should deal with. So some of the things that we previously have not done much work on, we're starting to do. So things like looking a little bit more between public health and mental health services access, looking more in terms of things like the trajectory of youth, trying to get them out of a trajectory that leads to incarceration. In fact, I think, Maura, we are funding a study that's looking at the juvenile mental health courts at the moment. And previously, in the last 2 years, we also started looking at the youth diversion teen courts with the Superior Court. Another example is that we've, through the population health programs and also at public health, we're actually examining community programs that actually have health benefits, but through a sort of social services and social cohesion lens. I know the county recently expanded the Parks After Dark program. This is a program in which they open parks and try to do a lot of programming and bring a lot of different services and interaction and community engagement to neighborhoods that have high crime areas, that have high crime rates. And this past year, we actually expanded to 21 parks. And some of the things we started looking at is actually crime rates and how, neighborhoods with these Parks After Dark program are actually doing a little better in terms of crime. And here's another example of presenting data on crime. And I should tell you that one of the reasons we're also very interested in, and I think why we're all here, is that DII methods and this work has a lot of interest. I've been with the county, this will be my 10th year, and I have to say that more and more as I go to these deputies meetings, the idea of effectiveness data, the idea of impact data has become more and more of a question. That is, I think decision makers are starting to make a lot more decisions and would like to see the type of data that we hopefully can continue to generate and should be able to generate more as we go. So finally, I just wanted to leave you with, again, this is the population health program under CTSI. These are our aims. A couple of things that came out of developing a population health program is that we recognize that in order for us to come together to do more of the dissemination and use of innovative methods, two things sort of have to happen. One, we have to continue to kind of develop young scientists and kind of reach a critical mass within the research circles, research community to actually do this work. But the other interesting one that we kind of concluded is that we've also probably need to build up the critical mass on the health system side, on the health agency side, on the health department side, because I think in order for this type of collaboration to happen, the consumer of the research should also know a lot more about some of these tasks and research methods we're thinking of. So anyway, thank you for the opportunity.
Thank you so much. I think we have just a few minutes left in this segment, so I wanted to see if there are perhaps one or two questions for anyone for Dr. Yi and Dr. Crowe regarding their comments or.
So for one or both of you, this is maybe a little tangential or next step. I'm wondering how you prioritize. You know, we heard a little bit about your limited resources, how important it is to solve real-world problems, and there's no shortage of problems. So, what kind of processes have you developed to prioritize, and how you're going to allocate?
I'll just speak for Department of Health Services. My sort of guiding mantra is how do we provide more high-quality, patient-centered care with the limited resources that we have. So anything that helps me solve that problem would be a high priority. The sort of tactics that I would take would be to help understand how we ensure that we're providing the right care at the right time by the right provider in the right location. Given the fact that my guess is that maybe I'm being a little hyperbolic, but I think in American healthcare, probably more than 90% of the time, the care that's being provided is either unnecessary, given in the wrong place, given by the wrong person, given at the wrong time. I think there's lots of places to make improvement without costing a lot of extra dollars.
From the public health standpoint, I think prioritizing, we've certainly relied a lot on population data, and we've the last few years been a lot better in terms of like hotspotting areas. For us, I don't think the priority in terms of the type of health problem that we have to tackle, they haven't really changed that much in terms of like heart disease, diabetes, and whatnot. I think our challenge is it's not just prioritizing, it's like once you prioritize, how do we more effectively leverage other existing resources and trying to achieve some alignment with other sectors so that it's more cost effective in the way we approach things.
Are there any other questions or comments? Okay. Well, right on time. So thank you so much. Thanks so much, Dr. Ho and Dr. Yi, for those comments. Really appreciate it. And we'll go forward into the next segment.
Morning. Let me first add my welcome to those you've heard and my thanks to all of you for joining us yet again for what is our third annual symposium on dissemination, implementation, improvement science. Many of you I know were here in 2014, the first 2015. We skipped last year, 2016, because of some issues related to funding cycles and where we were, but we're all glad to be back. I also wanted to thank Drs. Dubinett and Buchanan for introducing the session, but also for their ongoing support. There's been a bit of a struggle through the years with the CTSA program in terms of a balance in focus of attention on type 1 translation, clinical research, and basic science versus type 2, or what we prefer to refer to as implementation science. And both have been very supportive all along, recognizing that there is a full pipeline and that investment and attention to the implementation issues, the type 2, are critically important and are necessary for us to achieve the mission of the NIH roadmap, the CTSA program, and ultimately the mission of NIH. My primary assignment is to give you an overview of the day, but what I'd like to do is, for those of you who are new, try to catch you up on where we've been, but also those who have been here in the past, just a reminder. We started back in 2014 with an emphasis and a set of goals to, in a sense, raise awareness and interest and commitment to this sort of work. We had a couple of outside national speakers who helped to demonstrate the importance of this work and interest nationally. We also had a set of sessions that focused on developing basic skills, basic orientation. You remember that Loretta Jones and Ken Wells helped us all to get up to speed on community engagement and patient engagement. So that was really the focus of our first year. During the second year, we moved a little bit lower, closer to the ground, with an emphasis on training, continued recruitment and efforts to stimulate interest and engagement in this work, but more of a focus on barriers and facilitators and other steps that we could take to further increase and accelerate partner-oriented work of this sort. This year, we're even further down in the weeds or on the ground, and as you can see from a review of the program, our focus is very much on understanding details of successful projects. So we have a bit more time devoted to breakout sessions and small group activities, a little bit less time focused on plenary sessions. So our goal remains to try to stimulate and encourage more of this sort of partnership-oriented, collaborative work between the research and policy and practice communities, but again, with a heavy emphasis on what are the specific methods that have been used that are successful and that are needed. So with thanks to Drs. Yi and Crowe, again, for their opening remarks and their continued commitment to this work, some of the features, especially that Hal Yi mentioned, I think will be seen throughout the day in some of the sessions. We have is the first major plenary session, a set of projects that, as I said, attempt to illustrate the features of high-quality work in this area. A work that does take an effectiveness orientation, that does take a very practical view, that uses research approaches and methods, but does so in a way that attempts to generate improvements in the relatively near term as opposed to more long term. We follow that with a brief break, and then we move into a set of breakout sessions. Title is DII Methods and Practice Workshopping Our Ideas. And the goal of these is to focus in depth on specific projects with an emphasis on what makes those projects unique and successful. What are the specific methods, the specific approaches that are useful in ensuring that we do see a balanced mix of activity and achievement related to generalizable knowledge in science and research, as well as achievement related to practice and policy goals. And also a couple of sessions that are more of a planning sort that, again, operationalize one of the goals of the day, and that is to help stimulate and support new collaborations, new partnerships, and new project ideas. We will then move into a poster session followed by lunch, and then guided poster tours. In the foyer, you will see an easel with a set of poster tour sign-up sheets. We have 6 senior researchers who have agreed to serve as discussants or poster tour guides. Each of them will spend 10 or 15 minutes discussing 2 posters. We would encourage all of you to sign up for a poster tour. We have just over an hour for lunch. It will take a little bit less than a half hour, so plenty of time for you to eat as well as to learn and discuss. As to poster authors, it's up to you. If you'd like to hear your poster discussed, we welcome you to be there, but it's not meant to be interactive between the discussant and the poster author, but instead an opportunity for us to listen to the discussant, comment on some of the key features, strengths, and perhaps offer some suggestions as well. So that's the poster tour. We'll then reconvene at 12:45 for another plenary session with an overview of topics specifically related to learning health systems and what are the features of learning health systems, and again, how can we all facilitate the development and the success of learning health systems. We will then turn to another set of breakout sessions, again, that provide an opportunity for learning and detailed discussion in skill development, followed by a brief session where we will hear from each of those strategy sessions, brief report out, and then Michael Gould will close us with some comments and observations, and I think or hope some comments that will help us ensure that tomorrow morning we continue with the same level of motivation, the same level of engagement and activity. So a few housekeeping items that I've been assigned responsibility to cover. You head out into the foyer, turn left, and you'll find the restrooms. Lunch will be buffet style in the foyer as well. The posters are split between this room, a small set on my left, your right, as well as a Joshua tree, which is in that corner across from the restrooms. The breakout sessions, there's a map, by the way, in the booklet. But the breakout sessions are located here and in a set of rooms along the right side, my right, behind you to the left. Other housekeeping items. Evaluations, critically important, as well as a social network survey, is part of our broader goal to continue to stimulate and facilitate and support ongoing connections and collaborations and partnership. We're very eager to understand something about the social networks, the connections. Those of you who have been here in the past remember that we've done this before, and so we do plan to conduct some longitudinal analyses and understand how social networks have changed, and we hope strengthened over the years. But the evaluations also are critically important for us to understand what is useful, what we can do next year to continue achieving our goals. And then lastly, I believe, unless I get a hand gesture from Ibrahima, just a brief thanks to all of the sponsoring organizations. They are listed on the cover. This continues to be an effort that's co-hosted not only by the UCLA and USC CTSIs, who happen to be closest and therefore put in probably the bulk of the time and effort, but the other institutions that are listed as well. Kaiser, VA, UC Irvine, UC Riverside, UC San Diego. We do have representation from other parts of the state, as been noted, and that's part of our goal of sharing what we've learned and sharing what we believe are some of the unique features of this community. I think it's fair to say, and it's not inappropriate boasting, that this region and the institutions that are represented in this room are at the forefront of the sort of work that we're discussing today. Community-oriented, partnered, fully engaged research that focuses on dissemination, implementation, and improvement, that does so in a way that, again, simultaneously pursues both the science goals as well as the policy and practice goals. We feel that we do have a lot to offer and share with our counterparts elsewhere. And that, again, is one of the items on our list for follow-up for tomorrow. What can we do to not only further enhance our own activity, but ensure that others benefit as well? So again, unless there's anything that I've forgotten to cover by way of housekeeping, what I'd like to do is move us to the next session, introduce Dr. Sonali Saluja from USC, who will introduce our speakers and take us into the next part of the day. Thank you. Question, Michael.
So, as one of the 6 so-called experts who are doing the poster tours, can I make a request? can I make a request that the real experts, the people who did the work, be present at their posters, or at least, if it's not mandatory and you'd rather have a nice conversation over lunch, then no one's going to object strongly. But it'll be a much richer conversation if you're there to engage with the rest of us.
I think that's fair, and as another one of the so-called experts, I would agree. So please, for the authors. Yeah, so just a quick reminder on that topic, please do sign up for poster tours, a set of 8.5 by 11 sheets that are on an easel almost directly opposite of me. And you can do that during the poster session or at the start of lunch. So I think that's it. Okay, thank you.
Good morning, everyone. Thanks for coming today. Thank you for that great introduction, Dr. Mittman, and guide to the symposium. I'm going to be moderating the next session. And this session, you're going to hear about 4 projects that have utilized dissemination, implementation, and improvement science principles to really understand or tackle challenges for both health systems and for populations. So we have a lot of great projects to cover. So if we can actually have the presenters just come up on the stage here for the featured projects section. So we have a lot of great projects, and we don't have a whole lot of time, unfortunately. So we'll take questions at the very end of the presentations. Okay, so our first speaker is Dr. Lauren Deskovich, and she is the director of the Ophthalmology and Eye Health Program at the Los Angeles County Department of Health Services. She will be talking about her project on the implementation and evaluation of a large-scale Teleretinal diabetic retinopathy screening program in LA County. So I'll let her start. Okay.
Okay, that's both. There. Can I move that so I can see a little bit? Okay, good morning, everyone. I'm really happy to be here to talk to you about a program that has been a flagship initiative for eye health in DHS over the last 4 years, and certainly something that's near and dear to my heart. So first, I want to give you a little bit of background about diabetic retinopathy. As many of you may know, it's damage to the blood vessels in the retina caused by diabetes, and it's the leading cause of blindness in working-age adults throughout the U.S. and really internationally. A large study of Latinos, though, to bring this closer to home, in Los Angeles showed the prevalence of this disease to be 50%. So it really is the leading cause of blindness here in LA County. But it's treatable. So an early treatment diabetic retinopathy study, a landmark study in ophthalmology, showed that effective treatment of this disease can reduce severe vision loss by up to 94%. However, at least 40 to 45% of diabetics in the U.S. who could benefit from this treatment aren't receiving it because the screening rates are only about 60% nationwide. This number is even lower in the safety net, where U.S. intercity safety net clinic screening rates tend to be 25% or lower. And certainly 4 years ago, LA County was on par with that number. So to lay out the problem for you, historically, our screening process is I've depicted here schematically in the LA County DHS is that patients would come in, a diabetic patient would come into the primary care clinic where they would be seen, and then the patient were then, and this is either in our DHS facilities or in our community partner facilities throughout LA County, and then the patient would be referred into a county health facility for routine retinopathy screening, and this is either by ophthalmology or optometry, which is basically whatever eye clinic they can get into. And so often greater than 6 to 9 months from that referral time period, the patient would come in to be screened at the county health facility, if they showed up at all. You can see this is a pretty inadequate and inefficient way for an annual screening process. So the solution that we thought of was teleretinal screening. for diabetic retinopathy. Digital non-mydriatic camera images are effective for diabetic retinopathy screening. They have a high sensitivity and specificity. There's a plethora of literature out there, and the sensitivity and specificity approach 100% for sight-threatening disease. And this has been done successfully in other healthcare settings. There's examples in the literature of the VA, Jocelyn Vision Network, Indian Health Services, and even nationally this is done in the UK, NHS, and done successfully. Kaiser has examples as well. But there were no studies evaluating the effectiveness of teleretinal screening in a large urban safety net healthcare system such as ours. So here's the vision for what this would look like in our clinical setting here in DHS. The idea was that a patient would come in, a diabetic patient, for their PCP visit. Then at the end of that visit, they would be sent for teleretinal diabetic retinopathy screening in their primary care clinic. And that may be at the end of the visit, or they may return for it, but it happens there in primary care. The images are required. This is an example of a fundus camera that the photographers use. The photographers, who are primary care clinic staff, upload the image to the software template, which is remote and web-based, and then they submit that. The image is transmitted to a virtual reading center. Our certified readers, which in DHS are optometrists, review these images and generate a report back to the PCP. This is much like a lab test, a mammogram, a stress test. The PCP clinic then receives that report with actionable items. They submit an e-consult for eye care appointment based on the diagnosis and triage recommendations that are provided in that report. So as you can see, this is this entire screening process is centered around the primary care or diabetes care provider, which is the person that not only is central to this process, but central to the diabetes care overall. So the vision is one thing, but how do we implement that? So one of the things that was essential to implementation of something this large scale that crosses the LA County workforce, both primary care and specialty care, was the support of central and facility-based leadership. It was really a fundamental building block. But once that's in place, there's still a lot more building blocks to come. So starting with obtaining fundus cameras for 15 of the DHS primary care clinic sites that were targeted. 5 of these were actually obtained via donation from UCLA under the Telemedicine Prop 1D Act. And then we went on to identify and train fundus photographers, and these were at the certified medical assistant or LVN level and primary care clinic staff. But again, there is no certification of any particular stage needed. It was just primary care clinic staff, and we often use medical assistants in our primary care clinics. We selected and implemented the software platform for transmitting these teleretinal images, and then we certified our optometrists to be the primary readers, and implemented a QA quality assurance oversight protocol by ophthalmology. Then we established protocols for standardizing referral timelines by diagnosis across DHS, and then we integrated these referrals for abnormal results into eConsult, which was our new web-based LA County specialty referral system. This enabled us to access eye care clinic appointments throughout DHS, utilizing this limited resource throughout all of our facilities. So we didn't want to just implement it without knowing if we were actually this was accomplishing what we set out to do. So we wanted to evaluate it. And I partnered with the UCLA CTSI, specifically Dr. Carol Mangione and Chi-Hong Tsang, to ask the following research question. Are we truly meeting our goals of increasing the number of patients screened and triaging those in need of ophthalmology specialty care in a more timely manner? So put simply, are we screening more patients for diabetic retinopathy, and are the wait times shorter? In order to answer this question, we applied successfully for an LA County DHS and UCLA CTSI collaboration grant. Together with the UCLA team, we developed our specific aims for the grant, which I have outlined here. And you can see in all their scientific glory, Aim 1 is to assess the change in proportion of diabetics screened for diabetic retinopathy before and after our teleretinal screening intervention. Aim 2 is to evaluate the change in wait time from referral to definitive treatment for diabetic retinopathy before and after implementation of teleretinal screening. And then Aim 3, we wanted to compare those wait times by diagnosis for severity of retinopathy to see if they were guideline concordant with what the American Academy of Ophthalmology preferred practice patterns had set out. So here are the methods for our grant. We did a non-randomized quasi-experimental pre-test, post-test design. Exposure was at the clinic level with historical controls that were powered to detect a 15% difference in screening rate and wait times between the pre-test and post-test populations. And we looked at 5 of our clinics with 120 subjects per clinic per group. What does this look like? That was a lot of words. Here's the schematic. We looked at, again, the pre-test group of 120 patients in each 5 clinics that were randomly selected. And then in the post-test group, it was the same. Those 5 clinics, another 120 patients randomly selected 12 months, a year after the intervention. We did a pre-post analysis for screening rate, wait times, and then wait time to definitive treatment for more advanced levels of diabetic retinopathy. So in terms of results, our overall annual screening rates for diabetic retinopathy increased 16.3% at those 5 targeted clinics. You can see that's depicted graphically here, but this is an absolute screening rate from 40.6 before implementation to 56.9 after initiation of the program. It's a little harder to see, but the overall rate is the empty circle. So you can see it's significantly increased across all of our clinics. This is a real-world setting, so some different than others, but the rate went up across all. So for AIM-2, the median time to screening for diabetic retinopathy decreased 89.2%. That was 158 days before the implementation to 17 days after we initiated our program. And again, that significant decrease was seen across all 5 of our clinics. But importantly, in terms of the larger implementation, we eliminated the need for over 14,000 visits to the eye clinic in the first 2 years of the program. In a setting such as the LA County DHS safety net, where this is a high-demand specialty in a limited resource setting, this was really powerful. These are 14,000 visits that we saved for patients that really needed it for other sight-threatening eye disease. We published these results within the last month in JAMA Internal Medicine. So to bring you back, though, from that evaluation to the implementation, we did this evaluation in a smaller subset of clinics, which I've listed in bold here, and our evaluation was positive, but we were continuing to implement in a gradual rollout phase throughout all of LA County. So this is a list of where our active sites of screening are, and these are our largest primary care clinics throughout LA County DHS. The program has grown. We now have screened almost 41,000 patients, and the evaluation has continued to, what we saw in the evaluation has continued to bear out. 71% of these patients don't need to come into the eye clinic. We don't use ophthalmology or optometry appointments on these patients. They're saved for us to take care of other eye disease. And of the 18% that are referred for diabetic retinopathy, only 7% are referred for treatable disease. And these are patients that we can get into our tertiary level ophthalmology clinics where that acuity can be handled, and we can provide that treatment. So the program has continued to grow. The monthly, that I listed here, the monthly volume by year. And what you can see at the yellow arrow is when we finished our rollout period. Even since all clinics have rolled out, we've continued to grow in volume as this becomes integrated more and more into our workflows throughout all of our primary care clinics. And it's adopted by all of the primary care workforce, and we essentially get used to using this new way of screening for diabetic retinopathy in our patients. And we hope to continue to expand. We are now actually at about, our most recent screening rate is 60%. For diabetic retinopathy. So we've increased from that 40% before now to 60%. So in summary, this is an example of a successful implementation of teleretinal diabetic retinopathy screening in a large urban safety net healthcare system. In fact, this is the largest implementation of diabetic retinopathy in a safety net healthcare system in the U.S. And we built it from the ground up. We had to place the cameras, train the primary care photographers, establish the workflows, build the quality assurance protocols, standardize them across our system. And we also had to integrate this with the other technologies that we're using in our system. We integrated this with eConsult and into our EHR. And our evaluation showed that it's actually doing what we set out to do. We're screening more people much faster than we were before. So we want to continue that evaluation by building an analysis of cost, time to treatment, which was the AIM-3 that I mentioned before that we're still collecting data on, and also looking at our appropriate screening intervals to ensure that this program is continuing to meet the needs of our patient population. So the safety net is really an ideal place for implementing large-scale innovations, while at the same time applying scientific rigor to these innovations, to evaluations of these innovations to ensure that they're truly meeting our goal, which is to improve access to and quality of care, particularly in this case to improve screening and treatment for those that need it in a timely manner to prevent blindness. And I believe that's it. So thank you very much. I know my time's up. Thank you. And I don't know if we're going to do questions now or later. Okay, great.
Thank you, Dr. Daskovich, for that excellent presentation. Our next two presenters are Tara Rogers and Adam Sharp from Kaiser Permanente, Southern California, and they will be presenting their strategy for identifying, addressing, and understanding social determinants of health in their patient population.
Thank you, and thank you for having us. My name's Adam Sharp, and it's a pleasure to be here. This is a wonderful group, and I just want to say thank you for having a group who is interested in effectiveness versus efficacy. It was so nice to see wonderful research from Dr. Daskovich about quasi-experimental pre-post design that was absolutely awesome and effective, and an evaluation arm was built in, and that's kind of what we've been trying to do. This has been a paradigm culture shift for Kaiser Permanente. So just to introduce us, I'm an emergency physician and part of the research and evaluation team, CERT with Brian and Michael and Hong and many others. Tara has been the mastermind behind this project. I've been kind of on the evaluation arm, and so he'll be the nuts and bolts to answer any questions even after this, because there's not a lot of time here. But I hope to give you a broad overview. We can talk about some of the details of this later on. But in short, we've had a collaboration with Health Leads, which you may know is a non-for-profit based out of Boston. They've had an interesting model in screening for social needs in the clinic setting, and then helping to navigate for patients to connect them to social resources. We built in, that's where I kind of came in, an evaluation plan for our pilot. We'll talk a little bit about that. Then we're going to talk a little bit about some of the nuts and bolts of our patient perspective, as well as some of the process improvement efforts that have gone on that we've learned as we've gone over the last couple of years of this. And then we'll answer questions at the end. So to set the stage here, most of you being a California-based thing are familiar with Kaiser Permanente. We're big. In Southern California, we have 4-point-something million members now and have been growing every year. We have 14 different hospitals, a variety of different clinics. 3 of these were part of our pilot, as you can tell here. So West LA, Fontana, and Kern County. They're all slightly different. We already heard about the differences of West LA communities compared to South LA communities. Fontana's more representative of South LA communities. And Kern is a slightly different model because we don't own our hospital there. It's not a fully integrated system, so it's slightly different. To be brief, we changed Health Lead's model because what they did was not implementable nor disseminatable in our system. So we built a telephone, essentially community resource hub that was able to screen our patient population and refer them to local resources, and Health Leads helped with that. So we had never had, certainly we've had social workers, as many of you, but we'd never had a thoughtful approach in Kaiser to actually knowing what percentage of our members have social needs. So that was kind of step A, is how do we do this in a way that is feasible for large volume, large health system. And so centralized screening, finding validated questions to ask. We focused on things that you might think about: food insecurity, housing, transportation, help with medical costs if necessary, and utilities were the primary ones. We also talked a little bit about health literacy. So we have a variety of questions, but focused on those. And then the key to this was that we wanted to connect and follow up, as opposed to just give them a piece of paper or refer them to information. Our system never knew who followed up and who actually received services, and that was part of this. And then key to this is evaluating outcomes, as we've discussed. Did this actually change anything? It feels good to screen people that need food and say, here's a resource to get food. But for Kaiser, does that change a health outcome? And I think that is the big question that we're still trying to learn. We haven't answered it yet, but that's part of our hope. So since we're all implementation researchers here, this is a little bit of a framework. Did my fellowship at the University of Michigan, so this is Laura Damschroeder's CFIR setting. So in short, the characteristics of the intervention: our target population were predicted 1% high utilizers. Diagnostic cost group is the best example of kind of the algorithm that went into predicting who were the high utilizers. But this was a low-cost intervention that we could adapt to our needs. And it was primarily screening, navigating, and follow-up for patients with a social need. The inner and outer settings, I think, as a result of us being here, those were not barriers for us in this process, and I think that's an important component. I see on over there. So she can tell you about the predicted high utilizers. She's the mastermind behind that algorithm. But I mentioned this a little bit. Building an evaluation from the beginning has been important. This is a little bit of descriptive data. So this was interesting. Fortunately, we were able to actually get on the phone about 2/3 of the people. About 3/4 of those people were willing to actually be screened. And of those screened, more than half of them, 55% of Kaiser members in this predicted high utilizers had a social need. So the scope of this problem, which this is kind of our main result to this point for our institution, is this is a big deal, and it needs to be addressed in a thoughtful way. It can't be just one social worker at a time doing good work that we don't know about. And then we'll talk a little bit about why there's a little bit of an enrollment drop, and Artera will talk about what we've done about that. I won't spend a lot of time on this, but we've tried to describe the different social needs, and we have a variety of ways that we think that will help us to target the populations who need this most. Caregivers are key. That was all too true yesterday when I was working in the ER and a patient came in for a condition she'd known she'd had for 2 years, but wasn't able to get it treated because her mom she cares for, and just no one's going to care for her mom. So that's a big problem for us, and I think many, many others. With that, we have a mixed methods evaluation underway. So we're fortunate to work with people like Beth McGlynn and John Adams. They're helping us to use appropriate methods in our quasi-experimental pre-post effectiveness study here. But fortunately, we have some control groups, and so the plan is to use, as mentioned here, a propensity score difference in differences analysis. Our main outcomes will be total costs of care and utilization. I don't think we're going to meet those outcomes at this point, but I think in the future we may be better positioned to do so. So with that, I will turn the time over to Artera.
So what we were really focused on as we're underway with the evaluation is really trying to understand how can we improve on the model. As Adam mentioned earlier, there's a drop in enrollment, and we felt like enrollment was a huge indicator of how successful patients would connect with resources. So we decided to work with the Care Management Institute that's based in Northern California to really help us to get a patient perspective. We decided to use focus groups as well as surveys to try to glean some information from our members. And one thing that they really mentioned, they really resonated with the one-stop shop approach, liking having the call center because it's not information that they necessarily would volunteer to give us, but if we're asking as a healthcare provider, they felt comfortable answering those questions. But we started to really try to understand what were some of the barriers to successful connections. And some of the things that they talked about were unreasonable wait times that were associated with some of the community resource organizations. They also talked about having a negative impression of an organization that we may have referred them to, but not feeling empowered enough to say that they had reservations about that particular organization, and wanting us to provide kind of an action plan and wanting to see how this shaped into the long-term goal of their health care. So this is new for Kaiser Permanente to be talking about social needs and social barriers. So what does this have to do with health care? So we also wanted to look at some process metrics that were associated with this intervention as well. What does it take to actually connect a member with a social needs resource organization? Well, we started to see that it takes 13 attempts to contact the individual via a telephonic model. Only 7 of those 13 were successful. So right now we're in a process of trying to understand how do we create 7 successful contacts, whether it's through a telephonic approach or how do we integrate more within our system to have touch points along the way. One thing that we're really also focusing in on is the days to first referral. That essentially means the days that it takes for them to receive the resource organization information. the days on average was about 11. And I think that had to do with some resource organizations being more difficult or more challenging to research, especially as we're trying to address things like social isolation, understanding what type of resources match up with the patient's preferences. So we're doing some revision of scripting as well as our intake process so we can begin the matching process earlier. So we're really on this performance improvement journey right now. And when we started off, we really wanted to get people to screen. As Adam was mentioning, we wanted to get descriptive data around how social needs were impacting our membership. And so a lot of the focus was on increasing the number of calls, increasing the number of people screening. As we started to do that, later on we started to notice that the enrollment was actually dropping. And so we're in the process now of deploying motivational interviewing as well as understanding how do we remove some of the barriers through those motivational interviewing discussions from the first call. And then the last phase, which we're kind of doing simultaneously, is really delving into some of the social domains where we're seeing high success rates to understand how do we can develop social needs pathways associated with those, and seeing if there are lessons learned from our more successful resource connections that we can deploy to some of our not so successful resource connections. So we started this a little bit with a cohort that screened positive but refused to enroll into the navigation services that we provide. So as we deployed the motivational interviewing where we're asking about barriers, understanding their motivation, understanding their confidence to connect to these resource organizations, we've seen a trust build up quicker between the program associates and these individuals. And this is the same cohort we're looking at there, the predicted high utilizers, and this is about 6 months later. And we're seeing an increase of enrollment by 40% in our targeted motivational interviewing cohort. So we're hoping to kind of see how this works as we begin to ramp up more patients, because we're thinking about it from a scalability standpoint. We need more patients than about 580 patients to go through this. But this is a good starting point for us, and we're thinking that the motivational interviewing as well as addressing barriers is a good starting point for us to start to see higher enrollment, which we hope leads to better successful resource connections. So that's where we are today. As Adam was mentioning, we are in the midst of an evaluation process, but we're now also doing the performance improvement strategy simultaneously as well. So we'll be answering questions at the end.
Thank you, Mr. Rogers and Dr. Sharp. Next, we have Dr. Christine Thorn and Dr. Alan Fremont. Dr. Thorn is a preventive medicine physician at UC San Diego and the medical director of Be There San Diego. And Dr. Alan Fremont is a physician and sociologist at RAND and the co-chair of Be There San Diego. And they will be discussing their strategies to improve cardiovascular risk factors through a regional quality collaborative.
Good morning. Thank you for having me up from San Diego. I'm sorry Dr. Fremont couldn't be with us yet this morning. I'm hoping that he will be able to join us later. In the meantime, I did want to tell you a little bit about our work down in San Diego. We have an organization called Be There San Diego that grew out of the Right Care Initiative. And we have three main focuses of our work. One is to spread best practices around prevention of cardiovascular disease and management of cardiovascular disease risk factors. Another is to scale up evidence-based approaches to prevention of heart attacks and strokes. And third is to use data to motivate and to maintain progress and evaluate it. So I'm going to talk mostly about the work we're doing around the third part of this, but I will try to put it in context as we go. So this is our data quality collaborative, and as you can see, we have 12 different healthcare entities that are participating and providing us with data. This represents a wide variety of different healthcare settings, everything from Kaiser with its closed system through those with the asterisks above that are all FQHCs. We have academic setting and larger health systems as well who are participating. We have a total of 210,000 hypertensives that are represented in our data set, and this makes up about a third of the total patients with hypertension in San Diego County who are either have hypertension regardless of whether they know it. That's according to NHANES data. Every 2% change in blood pressure control in our data set means that another 4,200 patients have their hypertension under control. So even small gains mean a lot to the patients. We do have other data pieces that we look at. Some of the data points that we are following are hypertension control in diabetics, diabetic control of A1C, who is under good control, and who is in poor control with A1Cs greater than 9. I want to talk with you today about our work specifically around hypertension because we have focused on this quality metric largely over the last couple of years. Here is the control rates from 2010 to today. And as you can see, when your population is Kaiser, almost exclusively who's reporting in 2010, your control numbers look fantastic because they were already, really setting the benchmark for what could be done at that point. The reality is also that during those years, it was harder for some of the health systems and certainly at the FQHCs to even report this kind of data outside of their system. By 2013, you see a drop there, but then it comes back up. And so, by the end of 2016, that's where you have 210,000. And so I think that the work that we're doing is really showing a lot of fruit. That dip in 2013 represents going from having our population be almost exclusively Kaiser in the green to really bringing on a lot of different organizations. And as you can see, that red group that came on between 2012 and 2013 is the Council of Community Clinics. And it represents a population almost the same size as Kaiser's that is exclusively FQHC patients that are Medi-Cal patients. They're notoriously hard to control blood pressure and hard to engage in. So that explains the dip in our numbers. So just to show you kind of what it means to roll this out and what kind of an effect it can have on things like heart attack and stroke, I'm going to go over some of the Right Care Initiative's evaluation of the project from 2010 to 2014 in prevention of acute myocardial infarction. So this is yet to be published data, but as you can see, the blue graph is men and the red graph is women. The dotted lines are the overall acute MI rate, hospitalization rate for California, and the solid line is for San Diego. And as you can see, our numbers dropped considerably after the beginning of this initiative. This reduction is we decreased acute MIs 14% beyond that of the rest of California, and this represents preventing 2,300 MIs and a cost expenditure savings of $52 million. Just to give you an idea, we don't just look at hypertension, we don't just look at data. This is one piece that falls into a much larger pool of work that Be There San Diego is doing. From the clinical setting, where we had a heart attack and stroke-free zone project, which is his CMMI Innovation Award, efforts in healthcare system transformation, where we're scaling up things like clinical decision support tools and pharmacists on the care team, to community-based interventions, where we have engagement of patients in a faith-based setting that is even farther from the clinical setting. We do link back to clinics, but that work happens almost exclusively in the community, and then we do spend time linking that back. So achieving these kind of numbers doesn't just represent the work of the Data Quality Collaborative, it represents the work of Be There San Diego as a whole. And that takes place in a much larger context because we can't claim credit for a lot of other things that happened in San Diego that all contribute to this. Some of these are national, Affordable Care Act, JNC 8, changes in quality reporting, either in California, CMS, or movements to accountable care organizations, both public and private. Pay for performance measures coming online as really being motivating to a lot of these organizations. The advent of population health software. I mentioned that at the beginning of this collaborative, a lot of clinics couldn't easily report to us, and this is because their EHRs didn't really give them a good way to look at their patient population as a whole, much less report out numbers to others. But a lot of them had added on population health software that allows them to do data registries and to make those registries and those reports aligned with each other, and so they can report out to us. There was also a Measure Up, Pressure Down collaborative that was done in 2011 to 2013 that was San Diego was a pilot site for. So these things work together to achieve our goal. So our goal was to have 80% control of hypertension. We are currently at 79%. We actually hit 80% at one quarter last year. And this is greater than the HEDIS 90th percentile measures for 2015. So we're really achieving our goals. And as you can see, some of the clinics are really knocking it out of the park, and other clinics are struggling. So I wanted to talk to you about some of the factors in that question of effectiveness rather than efficacy. What are those clinics that are achieving their goals doing? And in relationship to us. So here are two clinics. The green line is our overall control rate. This is just quarters for the last 2 years. The blue line is a clinic that started out with a modest control rate, 10% below our goal, that is now leading our collaborative. And then we have another clinic that started out low and has really not seen a lot of change over the last 2 years. So the high impact group, has been really active in participating. They adopted our simplified approach to hypertension treatment just before the start of 2015. They spent 2015 really aggressively working on this, attending our groups, developing their own hypertension control workflow within their clinic. And then at the start of 2016, they started rolling this out and really implementing standardized training protocols around it, and that's where they saw the real bump. Their medical directors, we've noticed, attend our meetings very regularly. We have 9 meetings a year, and as you can see, over the course of 2 years, we have 20 different times that their medical director has attended. They also are active in participating in that Measure Up, Pressure Down collaborative, and they are a participant in our CMMI Innovation Heart Attack and Stroke Free Zone Prevention work. So the thing we have noticed with the group that's not changing much is that they are much less active in participating. They give us data, but they are much less likely to attend. Their medical director, while more on paper, is not always at the meetings, and they are just now rolling out their hypertension treatment approach within their own organization. They haven't signed on to as many of our other recommendations, and we think that this betrays, kind of 2 things. One is that the medical director themselves may not be either thinking that this is personally a very valuable thing, thinking that this is something they want to focus on, but it can also represent an organizational decision to not really support the medical director leaving in the middle of the day to go across town to talk to a bunch of other competitors' medical directors about what they can do. And so we think that's interesting, and we're hoping to learn more about that. Some of the feedback that we've gotten as to how people take these back to their teams is a little bit of that co-opetition of, we talk to our physicians in our organization and we say, the community clinics can do this. Why can't you with your patients? Because as we know, every doctor always has their patient panel that's the hardest panel of everybody else's patients, and they're always sicker. And when everybody can say, oh, the community clinics are doing it, then every MD gets their feathers ruffled a little bit and says, well, if they can do it, I can do it. It also makes the medical directors feel, lets them interact with their peers and see that other people are struggling, other systems are struggling with the same things they are. And they realize that, well, if they can do it and they're having these same struggles, and we talk openly and honestly in our collaborative, that they can do it too. And it allows you to benchmark to your peers. And I think the other thing is that we really focus on the group as a whole. And Dan Dworsky's quote here, which I won't read out because I'm out of time, really captures that we're really not picking on individual clinics. We're not spending our time doing that. We're really focusing on improving it as a region. So next steps are that we're developing a series of recommendations, and if you come to the workshop, that is one of the things I'll be talking about. We're looking at improving the quality of our data and expanding our reporting on measures, and then we're considering, we have the diabetes data, really spending more time focusing on how to improve diabetic control in our population. Thank you.
Thank you, Dr. Thorn. Our last presenter is Dr. Amy Cowan. She is the co-director of the Health Services Unit within the Veterans Administration Desert Pacific Mental Illness Research Educational and Clinical Center, and an associate research professor at UCLA. And she will be discussing strategies to address obesity in individuals with serious mental illness.
Good morning. The last speaker before the break to talk about obesity. Great. So I really appreciate this sort of rare opportunity to stop today and think. And so I hope we can all take advantage of that. Today I'm going to be talking about addressing obesity in individuals with serious mental illness. So people with serious mental illness, that's people with schizophrenia, schizoaffective disorder, bipolar disorder, psychotic depression, have very high rates of obesity and die 15 years prematurely, mostly due to diabetes and cardiovascular disease. One big reason for this is our second-generation antipsychotics, which are great for the positive symptoms of psychosis, but really bad for our waistline. You can gain about 10 pounds a month, and so we're talking about significant weight gain. Fortunately, as we all know, the harmful effects of obesity are reversible, and even with some modest weight loss, 5% weight loss, for example. Fortunately, there are also specialized in-person weight management programs tailored for this population that work great in clinical protocols and are, of course, included in treatment guidelines. But as everybody knows here, and as we've talked about this morning, it's not the same in our usual care clinics. There are many barriers to people participating in these interventions and gaining these outcomes. And in fact, they require considerable clinician time, a lot of patient travel, and as a result, utilization is very low and the impact is muted compared to what we see in protocols. So over the last several years, our group has been thinking a lot about how can we address this in this population. And we've thought a lot about using technology. And we have thought about the fact of delivering such programs online and using human interaction, social connection to strengthen that. And that's what I'm going to talk about today. So we developed the first interactive web-based system paired with peer coaches designed specifically for people with serious mental illness in order to self-manage their weight and live a sustained and healthy life. There we go. This program is tailored for this population who have a lot of cognitive deficits, limited literacy, and challenging social situations. The program is read aloud. It's at a 5th grade reading level, minimal text, simple presentations, and very clear navigation on each page. It educates users on diet and activity through 30 modules, 15 on each, and it provides choices for weekly goals, which individuals choose, and able to track their weight and their exercise. Each person's given a pedometer. It also manages the data on the back end for the research group and has a dashboard that are used by these peer coaches and their clinical supervisors. So when an individual logs on to do a module, again, there's 30 modules, it goes through sort of a typical flow. Every module has a typical flow, starting with the introduction to the topic and then going through content learning and then questions about their knowledge to make sure that they're understanding what's going on. Then they choose their personal goal for the week and then a review of the content. And I'm going to show you a couple screenshots of the program. So this is a typical page. You can see there's very little writing on it. There's a picture. Sometimes that's a video. This one says, today portions are being served at restaurants are bigger than they should be. This is called portion distortion. And you can see the clear navigation around the edges. This is a knowledge quiz. What is portion control? Understanding what a serving size is, a good way to decrease the amount of food you eat, a good way to lose weight. All of the above are correct. Again, very simple. My goal for this week is to eat meat portions no larger than a deck of cards, eat serving sizes of fruit no larger than a tennis ball, or pack half of restaurant food in a to-go box before starting my meal. Each of these had been covered in this module, and they choose one goal for the week. So the system also allows the person to track their weight and their steps. You can see a printout of that on the left side. They can also print out a quick summary of the module that they learned. And there are also other health tip pages that they can print out. For example, here about 10% weight loss. Now, peer coaches are often used in many of our healthcare systems, and we use them in VA. In fact, right now we have 1,095 peer coaches throughout the VA system, of which 191 are female coaches. In this project, we did a competitive hire for a VA salaried staff position for a peer coach on this project. And again, in the peer literature, there's a lot of debate about what the peerness is. In this project, we considered people who had serious mental illness, who were veterans, who had also struggled with their weight. We recruited from veterans organizations and made sure to always have at least one female veteran peer coach at all times so that our female veterans had a choice of a female coach. We trained the coaches both with didactics and experiential training. They did the peer coaching protocols manualized, and they were trained in motivational interviewing techniques. We also spent a lot of time talking about how to package their story. So many of them had not talked about their story of being a person with SMI and losing weight in a way that was efficient and actually helpful for the consumer, not just for them. We reviewed a lot about phone skills, multidisciplinary teamwork, and a lot about patient confidentiality. What happens if you run into one of your coachees at the grocery store, et cetera. We provided supervision 1 hour a week with a clinical psychologist. The peer coaches called individuals by phone weekly and followed a manualized session content. Again, as I mentioned before, there was a clinical dashboard. They could see for each of their patients the last time they logged on, how much time they spent on it. It was a little big brothery. What sessions they had done, what goals they'd picked, how they did on the knowledge quiz, if they had repeated a session. Then we used a call log that actually had key benchmarks of things they must cover in the call, and they recorded those. They had to review education and also talk about barriers and facilitators to the goal that the consumer picked. They provided motivation and support for behavior change. We also noted that they just provided just general support, and there was a lot of positive feeling from the consumers about the fact that someone from the VA was actually reaching out to them on a weekly basis. So we did a project testing out WebMove in usual care, and we had 276 individuals with serious mental illness. Everyone was on antipsychotic medication. We enrolled people with a BMI of 28 to 30. Those are people who are overweight. In that category, they had to also have been gaining 10 pounds over the last 3 months. We also took all people who were BMI in the obese range, that's 30.0 or above. We randomized individuals to 3 arms, WebMove, which is the program I just explained, comparing that to in-person groups using the same curriculum led by a master therapist supervised by a clinical psychologist, or usual care, which was an educational handout, and the ability to take advantage of any of the weight programs in the VA. There's a MOVE program, which has been out for not super successful, only enrolling about 5% of people who are eligible and only losing about 1 to 2 pounds over 6 months, but still it exists. We did assessments at 0, 3, and 6 months, compared changes of weight over time, and acceptability of the peer coaches. So what were our results? Well, in terms of weight, At 6 months in the obese group, the WebMove group, that's the online plus peer coaching, lost significant weight, 6 months average of 6 pounds, and the in-person and usual care had no weight change. The WebMove group had a higher percentage who lost 5% of their weight. In-person and usual care had significantly fewer who had lost 5% of their weight. The WebMove as a group completed a higher percentage of the program. They completed 49%. That's about 15 modules. And we had 31% of the people in this group who actually completed all 30 modules. That is in comparison to the in-person group, who completed significantly less of their program, which was actually only 24 in-person sessions. 41% of that program was completed. That's on average getting 10 sessions of in-person weight management. And we had absolutely no completers of all 24 sessions. It's probably not a surprise to anybody here. We did some qualitative interviews on using Atlas TI to examine them. And here are some quotes that people said about the peers. Without one-on-one coaching, the web program would not have been as good. The coach would explain things differently to me. That was the most helpful. Another one said, he wouldn't let me give up on myself. He was very supportive. It was helpful that he was there once a week. I had somebody to lean on a little bit. So there's considerable skepticism that people in the SMI population can actually use technology to change their health. But this project showed differently. In fact, the online weight management program with peer coaches specifically tailored to this population was feasible. It was well received. It led to lower weight. It's patient-centered. It gives service delivery on demand. It has little clinician burden. It's easy to update and modify as treatment guidelines change. And it's inexpensive to broadly disseminate or scale up. We recently published these results in JGIM. I wanted to recognize our large group of people who worked on this project. It was actually one of the most rewarding projects I worked on because we were able to be creative and also make healthcare changes. And actually one of our clinicians is here today. Sona, you want to raise your hand? She's one of the in-person clinicians. No hit on her that it didn't work. They just, thank you very much.
Thank you, Dr. Cowan. We now have some time for a few questions. So we can, hopefully people remember their questions, wrote them down. Feel free to ask the panelists. Yes.
The changes introducing the cameras. Thank you. Sorry. I'm not sure. Okay, I didn't know if this was on. Yeah, absolutely. Now, one of the key things to this whole implementation, I will say, is standardization. So we were doing this in a large healthcare system. We are not vertically integrated like so many of the places where just teleretinal screening in general was successful before. So I really took an approach of standardization and protocols with some understanding that there's going to be a balance with flexibility. Every site's different. This is real world. And there are, as others have alluded to, you're working with different folks that may have different priorities. But the way that we were able to implement in primary care is one, also by standardizing the amount of people that I would train. So I only trained 3 photographers per camera because one of the things everyone wants to do is, well, we'll just train everyone and then no one does it well. So it was really about getting buy-in and ownership of the individual photographers themselves, of those people that are taking the pictures and we went through a certification process with everyone. I have a program coordinator that would go through and provide like hands-on training, answer questions so that they really began to take ownership in their role and feel like they were actually making a difference in the patients' lives. We didn't quite get to the point, though I think it would be a great thing of, photographers being able to share initial information. And there are some sites that say they could even be, an initial triage point. And all of that just helps, the individual folks that are participating have more buy-in because it's an extra load on primary care clinics that are already handling so much. I think another thing that was helpful was for people to be able to see the end difference on the primary care provider or the diabetes provider side. So often they put a referral in and it went into the black hole. I'll be honest, some people kind of liked the black hole because at least it meant it was off their plate. And I get that when there's a lot of things that you're managing. But, you know, if you really saw the process through, and for anyone that, you know, there was a lot of pushback, I always sat down and met individually. And everyone can see in the end, like, look, your patients were, again, being seen 158 days from the time you put in the referral. Now you can screen them. And most people like being able to see the results. Before they would go into ophthalmology or optometry, and if your patient was seen, they'd have no idea. But on this end, you know, maybe you'd know the results, maybe you wouldn't. And here we were providing actionable results involving people in the care. It was another piece of information that they could use in caring for their patients in the entire diabetes picture. So I think, you know, it was the idea of, you know, providing protocols and support for these new roles, but then also showing how, while this is added work, it really improves the care that they're providing. And in many ways, though it sometimes is more down the line once you get that training and initial work done, it's actually making what they do more efficient and making their patients much happier.
Yes.
Sure. So the question is, can you speak to the challenges of employing peer coaches and whether they were paid or not? That sounds like a question from someone who's worked with peer coaches. So it is a challenging population. The good news is that the VA has taken a big investment in them and has national training and certification for them. So that helps because we sort of have a ready pool. We did pay them the going rate at the VA for peer coaches. Many of them had been had not been in the workplace for a long time. So that was really the challenge, was sort of getting them oriented to working again. But many of them had been around veterans a lot. And so there was this already nice framework for a relationship there. But there was definitely a lot of training around professional development, what to wear to work, how to, you know, what happens if you're sick, who do you call in, not completely bashing the VA on the phone call where you're coaching somebody, but also recognizing the fact that they were in the same population that probably had challenging environments. So, for example, one of the things that we found in the coaching supervision was that they were not great at generating a lot of different ideas to how to cook healthy food because they hadn't had that experience. So there was a lot in the supervision about teaching them, how do you buy a piece of fish? How do you cook that? How do you make something for one? You know, that kind of thing. And in fact, we found that the peer coaches lost weight, which was sort of interesting. And so it was an interesting thing. But it was definitely, would love to talk about it sometimes. It's a challenging population, but I definitely felt like the investment was worth it.
I think we have time for one more question. Yes. Oh, that's you. Sorry.
So for Dr. Thorn, what I heard you say was that, you know, this is there's kind of a big multi-level context with lots of stuff happening at different levels. And I'm wondering, and in addition to the learning collaborative that you've implemented and the other things that you're doing, can you tell us a little bit more about how you're thinking about what the crucial elements are, and within that larger context, what are the factors that are responsible for any successes that you've had?
Yeah, I think that there's a lot of pieces to this. I think the biggest thing was getting people together on a regular basis and really slowly building the trust so that they felt comfortable bringing their data, which is, you know, a relatively vulnerable state to be, to come and say, you know, our control numbers are only at 50% or such, and ask others for help and have frank discussions. And so there was a lot at the beginning that was just about bringing everybody to the table, making a table big enough, making enough space, and building the trust and not asking for too much at the start. And then as the years went on, I think building in the other pieces. So it started out really as the data sharing and the University of Best Practices. So just having people come together and talk, and even when they weren't sharing data, and then having them attend a lecture that was pertinent to their work. And a lot of those early lectures were around hypertension control. And then since then, we've built off of that, and they are willing to share more data. They speak more frankly about their data, about their struggles, about where they want to go with things, because they know everybody else in the room and they're not seeing them as competitors. We've also, we have multiple grants that we work on, and that has really enabled us to scale up some of the ideas and provide support for them to do it in their practices. And we don't just work with one group when we have a grant. We work across all of our different participants who are willing, and scale it up in all of them. So then you also have regular interaction around those grants and how they're implementing that. And so I think those things together have really helped.
All right, well, we are unfortunately out of time. Thank you so much to our presenters for sharing some really great projects with us. So our next session actually starts very soon here, and that's the workshops. And we have 4 workshops from which you can choose. Basically, they're all in different locations. There's 3 in this room. So what I recommend is taking a look at the titles and seeing what you're interested in. We also would like to keep the groups to be kind of relatively similar in size. So if you see that one of the workshops has a whole lot of people, you might want to consider checking out another one. And there is also a map on the back page of the booklet.
One quick note, since there are 3 in Yosemite, why don't we have the first Yosemite group, audit and feedback, take that corner. The second Yosemite group, barriers to effective ACA implementation, in the center. And then the third Yosemite group, which is the one that I'm leading, over in this corner. Thank you.